Hello to the webinar from Optimate, the first one, the Venous webinar tips and tricks. Welcome from Ettlingen, the main office of Optimate, to Vienna and to over 200 people from 30 countries in 4 continents. We say hello to Professor Schlager and Professor Wolf from the Medical University of Vienna. Today we're talking about 6 cases, diagnostic, the case itself, after the procedure and take-home messages. So please, Vienna, start.
Hello, also from my side, my name is Florian Wolf and I'm the Vice Chair of the Department of Division of Cardiovascular and Interventional Radiology at the Department of Biomedical Imaging and Image-Guided Therapy, very long name, and I work at the Medical University of Vienna. The topic of my talk is the superior vena cava syndrome. I have the impression that this is a topic nobody talks about, but it's present in everyday routine, and from the interventional radiology side, it's a relatively common thing that we do in our daily routine. First of all, what are the most common causes of the superior vena cava syndrome? It's the bronchial carcinoma, metastasis, lymphoma in many cases, even in young patients, or even shunts or pacemaker cables. The superior vena cava syndrome is an oncological emergency, and it's about 3 to 5% of all intrathoracic malignancies end up in that kind of oncological emergency. Other emergencies are, for example, when you think to the abdomen, it's a bowel perforation or an intestinal ischemia, and when you think on the brain, it's, for example, a cerebral herniation. In most cases, it's almost 80%, and the reason for the superior vena cava syndrome is a non-small cell lung cancer, or even in less cases a small cell lung cancer, and the other reasons are not so common. Most common is again the lymphoma. This is a very interesting drawing of the different types of manifestations of the superior vena cava syndrome. You can have the manifestation of a supraascigos superior vena cava obstruction. You have distended arm and neck veins, you have edema of the neck, of the face and of the arms, and you have dilated and tortuous vessels on the upper chest and the back. On the other hand, you can also have a manifestation of an infraascigos superior vena cava obstruction, and in this case the blood in the vena ascigos flows in the wrong direction, and you have more severe symptoms and even all the other symptoms from the first type of obstruction. There is also a classification, like for every pathology we know. You can have stage 1, this is stenosis less than 90%, it's just a stenosis and not an occlusion. You can have stage 2, this is between 90 and 99% stenosis of the superior vena cava, and you can have the more severe cases with an occlusion of the superior vena cava, or even occlusion of the superior vena cava and one or several of its tributaries. What I think is important, I'm a radiologist, that you have some kind of imaging before, and I definitely prefer to have CT imaging before any kind of treatment in a superior vena cava syndrome. Why do I want to have that? Because I want to localize the stenosis or occlusion. I want to have the diameter of the superior vena cava. I want to see if there is some thrombus above or below the occlusion. I want to check the access route, and I want to check what kind of stent I want to implant and how long the stent will be. I think a phlebography is only necessary in really rare cases, for example, when you have complex occlusions and when you want to plan your intervention. The access in most cases in my practice is the common femoral vein. This is easy. Alternatively, you can also have a brachial access, jugular access, or you can even use a dialysis shunt. We do it normally in local anesthesia. In most cases, we have a short 6 French sheath when you implant stents or larger stents, for example, a Venous XL stent. We have up to 10 French sheaths, but the size of the sheath in a venous intervention, as you know, is definitely not relevant. You can just compress the site of intervention after the intervention, and that's very quickly done and no problem for the patient, and complication rate is much lower than for arterial puncture. In most cases, you can use a standard wire. In difficult cases or occlusions, you need a stiff hydrophilic angel 035 guide wire. You might need a recanalization catheter, a snare loop, retrograde double access, and so on in the more complex cases. When we do stenting, we use in most cases the Optimod Venous XL stent. It's available in diameters between 16 and 36 millimeters and in lengths up to 100 millimeter. It's a 10 French system, and it's a very simple pullback mechanism to implant this type of stent. Relatively new in the market is the Optimate Venous XL Flex. It's available in diameters between 14 and 24 millimeters and in lengths up to 150 or 160 millimeters for the higher diameters. It's having really high radial force. It's very flexible, and it's especially for example, the brachiocephalic vein, it definitely makes sense to use this type of stent. Before the stent implantation, I do a PTA only in rare cases when there is really a severe stenosis or an occlusion. In most cases, I start with the implantation of the self-expanding stent followed by a PTA. This is in most cases sufficient. In most cases, a regular PTA balloon is sufficient with 12 or 14 millimeters, for example. And in rare cases, I use dedicated venous or larger PTA balloons. For example, the Optimate Celos a balloon that is available in diameters of up to 28 millimeters. What about the results? The success rate, as you all know from your daily routine, is really high. It's up to almost 100%. Recurrent symptoms come up in between 20 and 30%, and even the secondary patency is really high. So if it occludes or the stent gets instant stenosis or whatever, you can do a PTA or a restenting, and then the success rate is really high. The survival is not high, but this is because of the pathology. In most cases, these are really severe ill patients with large tumors, and so that the survival is not really high of this group of patients. The time to relief, this is really different. For example, to chemotherapy or radiation therapy, this is really fast. In most cases, you implant the stent, and in a few hours after implantation, there is definitely a symptom relief for the patient. I have now 6 cases for you. First patient is a 67-year-old female patient with a typical large tumor in the mediastinum. It's a small cell lung cancer, and you can see the CT imaging before. This is a high-grade stenosis. It's not an occlusion of the superior vena cava. And you can see on the right side the phlebography before. This is a pigtail catheter coming from the femoral vein, and you can see the high-grade stenosis a little bit above the heart. In these cases, I implanted a Venous XL stent with a diameter of 20 millimeter and a length of 60 millimeter, and I did a PTA after that with a balloon with a diameter of 12 millimeter and a length of 40 millimeter. What you always should try to do that you land in a healthy part of the vein, so that the stent is long enough to start in a healthy part and even to end up in a healthy part, so that you really have the stent in all the region where the tumor leads to the compression of the vein. In this case, you can see very nicely the inflow and the outflow of the stent, a very nice result after implantation. This is a few months later after therapy. The stent is still in place. You can see the chest X-ray in 2 planes. The stent is optimally in place, and it's fully expanded now. There is almost no more tumor visible, and the stent is fully open. There is no thrombus formation or other complications. Second case is a 72-year-old male patient, again with a small cell lung cancer, a huge horrible tumor in the upper mediastinum, and you can see this high-grade subtotal stenosis of the superior vena cava, and a little bit below it's occluded. I came again from the femoral vein. You can see here the common iliac vein. And you can see in the middle image there is the catheter in the superior caval vein. You can see the Assoc vein, and on the right side the catheter is in the brachiocephalic vein. In this case, my plan was to land below the division of the confluence of both veins. And here you can see the result after stent implantation. The middle image shows doing the injection from below so that you can see the superior caval vein, and the right image shows doing injection in the brachycephalic vein. In both cases, it's a nice inflow and outflow, and the result looks not so bad. But when you look on the CT imaging 2 days later, you can see that there is a high compression of the stent. Clinically, there was a relief for the patient, but when you look here, you can see the result is not very nice. What might make sense, and we have since about 1 year, we have a biplane angiography system. What might make sense is to have a second plane after stent implantation and after PTA in order to visualize if the stent is expanded in both planes. In this case, when you look on the CT scan on the right side, this is just a topogram. It looks like the stent is fully expanded, but when you would have a second plane, you would see that the stent is completely compressed in the AP direction. Clinically, there was relief for the patient, but unfortunately, patient died 2 weeks after that stent implantation because of the tumor. Third case is a 73-year-old male patient. You can see this really ugly looking squamous cell carcinoma in the upper anterior mediastinum. And you can see this high-grade subtotal stenosis there. Looking at the video on the right side on the CT imaging again, there is still a little perfused part of the superior caval vein, and there is also some thrombus formation around this high-grade stenosis. You can see the imaging before stent implantation was done, PTA was done. There was a relatively high recoil because of this hard tumor, but at the end, the clinical result and even the imaging result was not so bad for the patient. This is again a few weeks later imaging. You can see that the stent is now fully expanded. Tumor was shrinking because of the therapy, and the symptoms completely were gone, and the stent still was nicely in place and fully expanded with a nice clinical result and also a nice result in the imaging. Fourth case is a 54-year-old female patient, again a horrible large tumor in the upper mediastinum. So the reason for the CT imaging in this case was that there was a suspicion of pulmonary embolism. Until now the patient did know, or the doctors and the patient did not know that there was a large tumor in the chest. And patient had dyspnea and widened cervical veins, and you can see here this huge tumor, and there is also compression of the superior caval vein, a high-grade compression with these collaterals all around there. You can see here that the upper part of the superior vena cava is patent, and below you can see the tumor. It's not so nicely visible in this case because the compression again is in the AP plane. So when you would have the second plane, you would see that it's highly compressed. But I knew from CT where the tumor is, and I knew where to put the stent, and I again wanted to put it below the brachycephalic vein. Stent was implanted, and directly after the stent placement, we did a CT image biopsy, a CT guided biopsy of the tumor, and you can see here the result after stent implantation in CT. And 1 year later, tumor was regressive, was a nice result after chemotherapy and radiation therapy, and you can very nicely see that the stent is completely expanded, no thrombus formation in the stent, and a very nice result from the imaging side and even from the clinical side. 2 years later, patient still alive, clinically very nice results, stent is still there, has a little bit thrombus formation, wall adherent thrombus formation in the stent, but again still a very, very nice result. And you can see that the contrast media was applied via the left arm, and there's a very nice inflow and outflow through the stent. Next case is again not a very nice case. It's a patient with a bronchial carcinoma and an occlusion of the brachycephalic vein on both sides, on the left and on the right side. And you can see these heavy collaterals going all around there with a clinical superior vena cava syndrome. In this case, it was not so easy to do the recanalization. We needed a stiff-angled hydrophilic guide wire and a recanalization catheter, but at the end it was possible to bring the wires through the occlusion. We did a PTA on both sides, kissing PTA with 8 mm high pressure balloons, and we implanted self-expandable stents, simple peripheral stents there from the left and from the right side. There was a heavy recoil even after PTA. Result was not very nice when you look on the imaging after stent implantation and PTA. And 1 month later, patient had recurrent symptoms, and you can see that there is again stenosis in the stent, and we did a re-intervention. We did a PTA of both stents again, and additionally we implanted balloon expandable stents from the left and from the right side. But again, the result was not very nice, and the patient had 3 weeks later again recurrent symptoms, and you can see that there is a thrombus formation in the stents. In the meantime, there are 4 stents in place, 2 stents on the left and 2 stents on the right side, and we did a re-PTA, but the result again was not very nice there. This is one more time a PTA 1 month later, again just a balloon PTA there. But the recurrence in this case was really high because of this high compression of the vein. This is after the last PTA. You can see now the inflow from the left side and from the right side. In this moment it looks not so bad there. This is a CT imaging 2 months after stent placement and re-PTA and second re-PTA. And here it looks not so bad. We can image this video once more. You can see that the stents are now not so bad expanded. There is no more thrombus formation and the veins are now patent. So sometimes you have to really do a re-PTA, perhaps re-stenting and so on in order to have a sufficient result. Last case is a 69-year-old male patient with a bronchial carcinoma. The stenosis looks not so severe when you look on the phlebography on the left side, but the clinical symptoms were heavy for the patient, so we decided again to implant the stent. I can't tell you why, but in these cases we also implanted a simple peripheral stent, self-expandable 1460 millimeter stent. We did a PTA with a 10 millimeter balloon, and there was almost a 100% recoil after stent implantation, so again, not a very nice result. So this is my last case. We had it in the one of the first slides regarding the complication rate. The complication rate of this type of intervention is between 3 to 5%. I had never a complication beside one case. I had one patient with a stenosis like this, a high-grade stenosis of the superior vena cava. I implanted a stent, self-expandable stent, without any complication. I chatted with the patient, and then I did a PTA with a simple PTA balloon, 6 millimeter diameter, 40 millimeter length. And the patient, I inflated the balloon, the patient opened the eyes, and suddenly a huge amount of blood came out of his mouth, and 5 minutes later the patient was dead. So there was a rupture of the superior vena cava because of the tumor, a tumor rupture, and it was not possible to stabilize the patient in any way. Why do I tell you this story? Because I really think that you have to take care when you do interventions like this. In most cases it will be without any complications, but sometimes the complications can be really severe, and you have to keep this in mind when you do a PTA in these highly stenosed tumor veins of the superior vena cava. To sum up, the superior vena cava syndrome, it's not so uncommon. It's an oncological emergency. When you do treatments like this, you can really help the patient, so the relief of symptoms for the patient is really excellent, and the patient directly after intervention in most cases is really happy because he or she feels that it's getting better now. You should do this kind of venous stenting. It's a very important standard IR procedure. What is important, the stent should begin and end in healthy part of the vein if it's possible. In many cases it's not possible because the tumor is so large. The success rate is really high. I showed you that with a relatively low complication rate, but keep in mind there might be severe complications. I really recommend to use dedicated venous stents because of the better radial force of these stents compared to standard stents. And recurrence is definitely possible. It's not very common, but it is possible. And you can do a re-PTA, or you even can do some re-stent placement. This should be also no problem. Thank you very much.
So thank you very much, Professor Wolf, for your cases. If you have got any questions, you can write them on Slido. There will be a link under the video. So I think now we can start with Professor Schlager. At the moment, we haven't got any questions. So Professor Schlager, if you have now you can start, I think. Thank you very much, Professor Wolf.
Thank you very much. Good afternoon. My name is Oliver Schlager. I'm angiologist and interventionalist at the Department of Medicine, Division of Angiology at the Medical University of Vienna. My talk is on endovascular treatment of iliocaval and iliofemoral venous obstructions. And first of all, when talking of iliac vein obstructions, I think it is important to differ between thrombotic lesions, which are patients which have either an acute deep vein thrombosis of the iliac veins or a post-thrombotic syndrome with chronic obstructions. And on the other hand, we have patients with so-called nivel lesions, non-thrombotic iliac vein lesions. These are patients with a Turner syndrome, for example, without thrombosis, or patients which have tumors, cysts, or fibrosis. In this talk, I would like to focus on thrombosis and on thrombotic lesions. Venous thromboembolism is, of course, an important and a clinically relevant problem. The annual incidence of venous thromboembolism ranges between 0.04 and 2.69 per 1,000. And the post-thrombotic syndrome typically develops within the first 3 to 24 months after an acute DVT event. The PTS, again, is clinically relevant because it affects up to 50% of patients after an acute deep venous thrombosis, and clinically most severe forms of the PTS still affect up to 10% of patients after acute DVT. Regarding the pathophysiology of thrombosis and the post-thrombotic syndrome, acute thrombosis substantially affects venous hemodynamics. On the one side, it leads to an outflow obstruction, as you can see here, and on the other side, it causes an inflammatory response affecting the venous wall and the venous valves, leading to venous valvular reflux, and both components, the outflow obstruction on the one side and valvular reflux on the other side, then conjointly result in venous hypertension. And venous hypertension, again, clinically leads to the leg swelling, to skin changes, trophic skin changes, up to ulcerations in some cases, and venous claudication, which is a common symptom in patients with proximal venous obstructions. And the crucial point is that this all often affect young patients. These are patients which are active, they have an acute DVT, and after that acute DVT, they may be really hampered in daily living. They have severe impairments of their quality of life and of patients' functioning. So therefore, it is important to think of strategies that prevent the occurrence and the development of the post-thrombotic syndrome. And one strategy is the so-called open vein hypothesis. The open vein hypothesis says that the early clot removal of an acutely occluded vein reduces the risk of chronification, of lesion chronification, and of the development of the post-thrombotic syndrome. Let me illustrate this with a brief clinical case example. This is a case of a 35-year-old young male patient. He came to our vascular outpatients clinic with a severe swelling of his left leg, a sudden onset. The onset was about 6 to 8 hours ago. And so far, the medical history of this young man was totally uneventful. We first, of course, did a duplex scan of his left leg. As you can see here, his iliac veins were totally occluded with fresh thrombotic material, and the thrombus was reaching down into the common femoral vein, also affecting the superficial and the deep femoral vein, with fresh clot. We discussed the possible treatment options with this young man, and then we decided for interventional treatment. This patient went to the cath lab where we did a puncture of his left-sided popliteal vein under ultrasound guidance. We injected contrast media, and as you can see here, the contrast media stopped at the level of the confluence of the deep and superficial femoral vein, and the iliac veins were totally blocked by fresh thrombotic material. After wire passage, we did a so-called pharmacomechanical thrombolysis in this patient, which is a combination treatment of mechanical thrombectomy and pharmacological lysis, and therefore we used the angiojet system with a DVT Celante catheter. We did 3 runs in one session. The first run was a suction run in suction mode, by which we removed fresh thrombotic material. Then we did a second run in the pulse spray mode, by which we injected a thrombolytic agent. In this patient, we used RTPA into the thrombus. We waited for 20 to 30 minutes, and then we did a third run in the same session in the suction mode again to remove any loose thrombotic material. And the first angio after this is shown here. As you can see, we cleared up the iliac veins as well as the common femoral vein. However, when going up north to the vena cava, you can see here that the confluence to the vena cava was still blocked. So what is the underlying reason? It is, of course, a Materna anatomy in this patient, which is a compression of the left-sided common iliac vein between the crossing artery and the spine. And the question is, how can this be detected? You can see it here. It can be detected by IVUS. Can you please stop the video right now? As you can see here, we are with the IVUS probe in the vena cava. We are pulling back the IVUS probe, and you will see when we restart the video that at about 3 to 4 o'clock, the contralateral artery is coming in and will cross the vein. Please restart the video. The artery is coming in here. Please stop the video once more. You can clearly see that the vein is totally flat under the artery. And what is really nice in intravascular ultrasound is that you have a live image here, which means that you can do provocation maneuvers with the patient. You can ask the patient to take some deep breaths, for example, or to press, and you will see in live mode how the vein responds to these maneuvers. Please restart the video. Now we're pulling down the probe into the external iliac vein, and you can see here how the vein opens up again, and here the vein looks normal. So intravascular ultrasound is really important in deep venous interventions to detect these underlying deep iliac vein obstructions. And this was also shown by a nice trial. This is the video trial. This was a comparative imaging study which compared the use of IVUS with multiplane catheter venography. And the video trial demonstrated that about in 1/4 of cases, iliac vein obstructions were only found by IVUS and were not detected even by multiplane venography. So therefore, IVUS is really important in deep venous interventions. We detected this lesion there by IVUS. Then we did a predilation with this 1640 millimeters balloon, and then we implanted a dedicated venous stent, a Materna stent. It is a special Materna stent, the sinus obliquus stent, which is designed for these lesions. It has some special features. You can see that the proximal central part of the stent is oblique, which prevents a jailing of the contralateral side. The lower margin of the stent should go about 5 to 10 millimeters up into the vena cava. This is a hybrid stent, which means the proximal central part of the stent is a closed cell design part, which has a very high radial resistive force and which opens up the Materna lesion. The more distal part is an open cell design part, which is more flexible, and the end of the stent again has a short closed cell ring. And in the end, we had quite a nice result in the angio as well as on ultrasound, as you can see here, in the external iliac vein as well as in the common femoral vein, where we had a really nice flow modulation after the intervention. The patient left the hospital 1 day after this intervention and was free of symptoms. The question is, what does current literature tell us to endovascular treatment of acute deep venous thrombosis? And so far we have several prospective randomized controlled trials addressing this issue. The 2 most recent and also probably most discussed ones are these 2, the ATTRACT trial, which was a prospective RCT from the US coming, and the cava trial, which was a Dutch prospective randomized controlled trial. And both studies included patients with acute DVT. In both studies, patients were randomized to receive either interventional treatment of acute DVT followed by anticoagulation versus anticoagulation only. And the results of these trials were pretty disappointing in the first sight for the interventional community, because there was no difference in respect to the occurrence of the post-thrombotic syndrome between the interventional treatment arm and the conservative treatment arm. And this was the primary endpoint, the reduction of the post-thrombotic syndrome. So I personally believe that we have a lot of learning points we can take away from these trials, and I think they are important, but I also believe that there are patients who will benefit from interventional treatment of acute deep venous thrombosis. And I will show you some points. I will try to highlight these points of discussion one should have in mind when reading these two studies. First of all, regarding the ATTRACT trial. In ATTRACT, they included a mixed study population, which means they included patients with iliac DVT, but also patients with femoropopliteal DVT. And we know from previous studies that patients with distal fempop DVT respond very well to conservative medical treatment, and they have a very low risk for the development of the post-thrombotic syndrome. In contrast, patients with iliac DVT have a high risk for the development of the post-thrombotic syndrome, and therefore this mixture of patients might have contributed to the negative trial result. Another point is that many patients with iliac deep vein thrombosis have underlying stenotic lesions, compression syndromes in the iliac veins as origin for the deep vein thrombosis. And these lesions have to be identified during intervention. And the best way to identify these lesions is the use of intravascular ultrasound, as I've demonstrated before. Unfortunately, in ATTRACT, there was no systemic use of IVUS in the whole study. And this might be one reason for the low stent rate in these patients. You can see here the stent rate in ATTRACT was 28%. And when you have in mind previous imaging studies in patients with iliac vein DVT, we know that these patients have a compression rate of 60 to 80% in the iliac veins. So therefore, this low stent rate is maybe another explanation for the negative trial result. Of course, it is important to use modern dedicated venous stents when treating these patients. Regarding the Dutch cava trial, the major limitation is a statistical one, because this study was totally underpowered. There was quite a large proportion of patients who withdrew consent after initial inclusion into this study, and another proportion of patients were lost to follow-up. Taking both studies together, one critical issue is that we have to think about rating the post-thrombotic syndrome as binary outcome measure. I think this is really a problem, because the post-thrombotic syndrome is a very multifaceted problem with a large spectrum of different symptoms. And by using a binary measure, which is either black or white, presence or absence of the post-thrombotic syndrome, might be another problem when discussing these trials. So therefore, as I've told you, I think we have to select the right patients, young patients with iliac vein DVT and a short history of symptoms. These are the patients who will benefit from acute treatment of this DVT. Nevertheless, we will also face patients with severe post-thrombotic lesions, with chronic thrombotic lesions, as I can show you here in this example. This is a young female patient, an 18-year-old young woman who presented at our outpatients clinic with a chronic swelling and feeling of heaviness in both legs, typical venous claudication, as you can see here, and severe venous collaterals. She had a history of an extensive iliocaval vein thrombosis about 1 year ago. We did a preparation with an MR venography and a duplex scan in this patient. And then Florian, Wolf, and I did the intervention together. We punctured the superficial femoral vein on both sides. And then you can see here the severely affected iliac veins and the totally obstructed vena cava in this young female patient. You also can see here the extensive collateral circulation of veins. We managed to cross these lesions, did a pre-ballooning here, and then we implanted a stent into the vena cava, a dedicated vena stent, and we prolonged the stents on both sides into the iliac veins. This intervention is now about 4.5 years ago. I saw this patient a few weeks ago. She's still free of symptoms. All stents are patent. So this is something which really helps young patients who are affected by severe venous occlusions. What do current recommendations of the societies tell us? You can see here the recommendations of the European Society of Vascular Surgery, which says that in patients with clinically relevant venous obstructions, stent recanalization should be considered. The American recommendation refers to the CEOP classification, which says that from CEOP class C4 on, stent recanalization should be considered. And the recommendation of the Radiological Society says that from CEOP class C3 on, recanalization should be considered. I personally think it's always a personal impression. Lifestyle limitation in a patient should undergo further evaluation for venous stenting. Regarding the procedure at all, I think it is important to do a good preparation of these procedures. As in all endovascular procedures, of course, you have to choose the right exercise as well as the position of the patient, either supine or a prone position. Regarding vascular access in acute patients, we mostly use a popliteal access. In chronic patients, in most cases, we use an access via the superficial femoral vein. I would recommend to avoid the common femoral vein directly in the groin, because in many chronic patients these lesions go down into the common femoral vein, and you will have to prolong the stents down distal from the inguinal ligament into the common femoral vein, which will not be possible if you puncture there. A jugular access is also helpful in many patients. Of course, a selection of guide wires and support catheters. I personally think that IVUS is essential in patients with chronic and acute venous occlusions, non-compliant high-pressure balloons, and of course a selection of modern dedicated venous stents should be in place. Regarding venous stents, we have also to differ between the different iliac segments. As you can see here, in the common iliac vein, we need a high resistive force, distal flexibility, and a crush resistance. We usually use a stent diameter of 16 or 14 millimeters. In the external iliac vein, we need a high flexibility. In this segment, we usually use a diameter of 14 millimeters. And in the common femoral vein and beyond the inguinal ligament, we need a high crush resistance, of course, and flexibility. In this segment, we usually use stents with a diameter of 12 to 14 millimeters. Regarding patients with acute clots and acute thrombosis, there is, of course, a selection of different thrombolytic catheters and pharmacomechanical thrombolysis devices. As you can see here, Trellis is, of course, not long on the market. We use the Angiojet system in most cases, or Indigo Penumbra or Asperex, but there are many other devices and also devices coming up in the future. What is also important is that the treatment of the patient does not end when the patient leaves the table of the cath lab. So I think you have to have a concept for the anticoagulation management after the procedure. Analgesics treatment is important, especially in patients with chronic lesions. These treatments can be painful, and a close duplex sonographic follow-up is also very important and should be provided to all patients after iliac vein interventions. Regarding the risk of recurrence, this is a function of three major points. On the one hand, it depends on the underlying lesion type. It differs between patients with acute thrombotic lesions and patients with chronic post-thrombotic lesions. It is also a function of the hemodynamics, which means a good inflow from below is also the key point. And then it also depends on the anticoagulation management. Fortunately, we know from many studies, and for example from this meta-analysis, that in all patency rates are quite good after venous recanalization of the iliac veins. You see that there are some differences between acute patients, chronic patients, and of course non-thrombotic patients. However, we have here really quite good results, and in the newer studies that came up during the last month, we even saw better results. So Let me finalize this with some take-home messages. I think careful patient selection is very important. Patients with iliocaval or iliofemoral thrombotic, acute thrombotic or chronic post-thrombotic patients can be treated by endovascular approaches. However, you always have to check the inflow from below. We have treatment options for acute and chronic cases. Equipment, expertise, and environment is important. As I've told you before, good preparation of the procedure, infrastructure, and also close follow-up of these after the intervention. And the anticoagulation management of these patients is also a big issue and should be provided by the respective clinic. Thank you very much.
Thank you very much, Professor Schlager. I think you've done a fantastic job, so there are only one question. And this question is, how many cases of Turner done in a year?
Do you mean non-thrombotic cases?
Yeah.
Yeah. Okay, actually we are doing right now about 30 venous interventions in the iliac veins per year, and I would say non-thrombotic iliac vein lesions without thrombosis is about, let's say, 5 cases.
Okay, thank you. If you have any more question, you can send us an email on education@optimate.com. You also can download over the link our actual product catalog, where you can find the applicators and all other stands we have got. Also, you can download in a few days the webinar or watch them on our website, optimate.com. So,
can I ask one question or two questions to Professor Schlager?
Yes, sorry.
First of all, technically, obviously, everything is possible. Why is it still so that many patients, even in the acute setting, but also in the chronic setting, do not land on our table? I think this is a topic in many centers and even in our center.
Well, I think, at least in Austria, it is so that I think many physicians are not aware of these treatment options, and therefore this is one reason why both of us are doing talks and lectures and webinars to provide and to distribute the knowledge to clinicians and physicians who treat patients with deep vein thrombosis. I think it is important to have a close collaboration between physicians who see patients with acute or chronic symptoms. This is the answer for the acute cases. Regarding the chronic cases, in my opinion, one major problem is that we have a huge amount of clinical research and on studies dealing with acute DVT and venous thromboembolism from the anticoagulation point of view. And we are focusing on recurrence of VTE and on bleeding, but we are not focusing on symptoms patients have after 1 year or after 2 years. And this is really a problem. Patients are often left alone with chronic symptoms, and many clinicians who see these patients do not have in mind that we have treatment options for these chronic occlusions.
Yes, I think this is really a problem. I have a friend of mine who is dermatologist, and I talked to him and I told him, oh, we can do now so great things. We can open up the iliac veins and we can put stents there. And he looked at me and he just said, why should we do that? Or why should you do that? Because we have all this anticoagulation and so on, and they are really not aware of this. My second question would be about the anticoagulation. I think this is also a very important point. So what is your management after stent placement in these patients?
Yeah. The anticoagulation question is a broadly discussed question regarding venous interventions, and we are currently also participating in a clinical trial. We do it like this. We start with unfractionated heparin for 24 hours. after that, we switched to low molecular weight heparin in a therapeutic dose for, let's say, 2 weeks, in general 2 or 3 weeks. And then we switched to an oral anticoagulation, which can either be a vitamin K antagonist, Macoma for example, or a DOAC. But the problem is that this is something which is done in a sort of freestyle mode in many countries. And there was a nice publication 2 or 3 years ago in the European Journal of Vascular and Endovascular Surgery. They did an electronic survey in the UK and also in Europe, and asked vascular experts what anticoagulation regime they would recommend for patients after venous stenting. And what came out is that there was a broad spectrum of, let's say, 15 to 20 different anticoagulation regimes for these patients. So this really is a problem, and therefore it is important to generate new data and to find a consensus on anticoagulation strategies after venous stent placement.
Last but not least, one more question. We know it from the last years when we did these interventions, and even you showed it, what is the reason for recurrency. And one reason for recurrency is that you end up not in the healthy part of the vein. So when the patients come back, you have to put in more stents and go more distally. And we know that in many cases we have to end up proximally in the region of the trochanter minor. So this is something we never did in interventional radiology or angiology, that we put stents in this inguinal region. Mm-hmm. Is there any long-term data about this kind of treatments, or even if there are stents going so far below, and because this is a highly compression of the stent during the movement, during walking and so on. Are there any data available what happens to the stents after
actually,
years?
there still are newer data coming up. We have a little bit older data coming from the US, from Peter Negland, for example, showing that of course, the patency of the stents depend on the length of the lesion, which means that when you have to go very far down, in all, you have lower patency rates. However, if you leave severe stenotic lesion in the common femoral vein untreated, you will end up with a soon recurrence and soon reocclusion of the stent. So this again is the problem, that you will have to find a balance between making the decision whether to treat this patient or not to treat this patient, and where to end the stent. From my personal point of view, these interventions are technically not that much challenging. I personally think the challenging thing is to decide which patient to treat and which patient not to treat, and where to land the stent and where not to land the stent. These are the difficult decisions in my impression. And regarding the inguinal ligament, the new dedicated venous stents are very flexible, and there are cases of stent fractures under the inguinal ligament, but the relevance is also not known. So we see in the literature we have cases with stent fractures which do not have recurrence, and we also have patients with rethrombosis. So I think this is something where we still have to collect future data. May I in turn also ask a question to Florian regarding the superior vena cava? What I find interesting is that there seems to be a difference regarding the treatment strategy with respect to pre-dilation of the lesion and also post-dilation. As you've shown, or as we both have shown, in the iliac veins, we usually dilate to the nominal diameter of the stent, which means, for example, in the common iliac vein, we use a 16 millimeter balloon for pre-dilation, and then we implant a 16 millimeter stent and do the post-dilation with a 16 millimeter balloon. Why do you think you should not do this in the superior vena cava, or what do you think is the difference in this segment?
You're completely right. We know from the iliac veins that we have to dilate before really heavily and then can put the stent there with the dedicated size for the vein. In the tumor stenosis, I would not do that because the risk of rupture is really high. The vessel, the vein is often completely destroyed there, and you really have to take care not to rupture the vein.
And if it's not underlying tumor, if it's just a fibrotic material scarring?
In this case, it might make sense to do a regular pre-dilatation before stent place, like in iliac vein. Yeah.
Okay, thank you very much. We have got one more question. And did you also use heparin at the other condition like the deep vein thrombose?
You mean in the superior vena cava syndrome?
Yeah.
No, not on a regular basis, no. Many of these patients are on heparin because of other reasons, but on a regular basis, no.
Okay, then another question. Now the questions are coming, I think. Now, in a case of placing dedicated stent under inguinal ligament, would you suggest some relaxation to the patient, for example, doing a squat?
Irgendwelche Sit-ups.
You mean you would suggest to whether I recommend the patients not to do
a squat
training
or whatever? Yeah.
Well, my common suggestion to the patients is to refrain from strenuous exercise for 1 to 2 weeks after the intervention. But to be honest, this does not really depend on the exact stent position, whether it's under the inguinal ligament or not. The young woman I showed, this 18-year-old woman, actually does a lot of training, and I have marathon runners and a lot of very sportive young people who have stents beyond the inguinal ligament, and it's not really a huge problem for them.
Okay. Fantastic. Would you say anything now also to the viewers now at the moment?
Sorry, I did not understand this question. Would I?
Have you any things you want to say now also to the viewers? Because we haven't got any questions.
To the viewers, okay. No, I think what is important is that it's like always in interventional treatment or in endovascular treatment, that you always have to have in mind the clinical symptoms of the patient and the imaging. And it's not treating an image, it's always treating a patient. And I also have young patients with severely obstructed iliac veins which do not have any complaints, and which also are very sporty young patients. So it always depends on the clinical symptoms. However, if you decide to treat these patients, it's also important, out of my point of view, not only to offer the intervention, but also to offer a follow-up treatment after this. And this can be done either by the radiologist, if he takes care of this, or by a vascular physician, or by a surgeon, or whoever, but it should be offered to the patient.
Okay, fantastic. Thank you very, very much, Professor Schlager and Professor Wolf, to have time today. And thank you to everybody who visit us today at the webinar. If you have any question, we say you can send us an email on education@optimed.com, and also see the webinar in a few days on optimed.com. These are my last words. We have 5 minutes left, but I think if there aren't any questions, we go home. Thank you very much for your time, you both, and take care and stay healthy.
Thank you. Stay healthy.